Yes, it's becoming an increasingly important question as more and more agents become available for this patient population. It's very tempting to utilize treatments with a potential for cure in large B-cell lymphoma, such as CAR T cells or now bispecifics. But we have to keep in mind that unfortunately some patients are elderly and have comorbid health conditions that will not help to utilize any of those treatments without running into major risks. So when it comes to a patient population like this, first of all, in the frontline setting, we try, if possible, to minimize the use of chemotherapy, and instead of standard R-CHOP, we'll utilize a lower dose, such as mini R-CHOP. There's recently been a trial where biological therapy has been used instead, with a combination of rituximab and loncastuximab. The activity was quite good, but unfortunately, there were some deaths due to respiratory complications that eventually were associated not to the treatment itself, but to previous conditions. And it's unfortunate that this combination is not moving forward, in my opinion. For patients who have non-GCB large B-cell lymphoma in the frontline setting, I will still sometimes utilize a combination of a BTK inhibitor and lenalidomide. And it's very easy to manage, and I will usually observe very good results and very long-lasting results. When it comes to relapsed refractory patients, in my opinion, it's not worth the risk of utilizing CAR T-cell therapy or bispecific. And I'm even referring to safe to use, say, CAR T-cell products such as Lisa-cel or Tisa-cel. And I think it's important to instead look into alternative treatments. We now have very long-term follow-up data for tafasitamab, an anti-CD19 monoclonal antibody, in combination with lenalidomide. And independently from the cell of origin, patient seems to potentially achieve a plateau that may be relevant for very elderly patients. And usually this combination is easier to manage in this patient population.